Good evening, doctors. At the outset, I would like to express my deep gratitude and very sincere thanks to all of you for graciously accepting our invitation to join today's webinar titled Real World Dilemmas in Heart Failure. We in ARIS feel privileged and advantaged in presenting to you three extremely illustrious, distinguished, and eminent cardiologists in the world who not only are exceptionally outstanding teachers, they are also erudite speakers, and I must say that they are the researchers. Uh, this basically is not a new name to you, and all our efforts, based on scientific foundation, the patient's first disposition, and the eagerness to enable the doctors to improve the clinical outcomes, have made ARIS Life Sciences synonymous with diabetes management and cardiovascular care. I myself, and on behalf of ARIS, thank you very sincerely for what we are today. Uh, I'm very sure that. That the scientific insights that they will provide to you in the domain of heart failure will be so invaluable and so insightful that it will eventually help you in those insights into your clinical applications. Needless to say that our interest in the domain of heart failure has now enhanced, especially after the introduction of two very important landmark introductions in India. One is dapagliflozin and another is ARni. And today's program is going to be moderated by the doyen among cardiologists, that is C.K. Ponde, who is joining us from Mumbai. Now, Dr. C.K. Ponde, to introduce to you, I must say what he is not. Because he is, see his qualification, he is MD, DM, DNB, FSCC, FSCAI, FESC, FCSI, FIAE, FIAC, FICC. Sorry for my breathlessness. He is a gold medalist throughout his undergraduate and postgraduate career. He earned the fellowship in interventional cardiology and electrophysiology from Brisbane, Australia, from 1993 to 1997. He is a recipient of several awards like Paul Harris Fellowship in 1995, Olympian Health Award in 1997, Rashtriya Manseva Puraskar 1999, and National Primetime Award in 2016. He has, to his credit, 100 publications in various national and international journals and also peer-reviewed journals, and has delivered more than 500 lectures in various national and international conferences. He received Inspiring Cardiologist of India Award by Economic Times of India 2020. Currently, he is the Vice President of Indian Academy of Echocardiography, and currently he is a consultant cardiologist and head of the department of a very reputed institute, Hinduja National Hospital, Mumbai. So I'm extremely delighted to present to you Dr. C.K. Ponde. Over to you, sir. Thank you.
Thank you, Dr. Joshi, for those kind words. We have the topic of today's dilemmas in heart failure, and we have two very, very brilliant speakers with us. One is Dr. Ajit Mullasari, and second is Dr. John McMurray. Dr. Ajit Mullasari, I would like to introduce him first. Ajit and me studied together, learned together, and grew together. He is the Director of Cardiology at the Madras Medical Mission, Chennai. He is the founder member of STEMI India. He is the primary investigator for several clinical trials like Extract-TIMI-25, Olympia Taxus Registry, Spirit-V Registry, and the Cosima trial, etc., which are well known to all of us. And he has received several awards like Lifetime Achievement Award of 2011 by the Imtar Medical University for the contribution of cardiology by the government of Tamil Nadu, Melvin Jones Millennium Award in the same year for the community service by the Lions Club International, then Charaka Award 2013, which is one of the awards with very high esteem by Rotary Club of Guindy for medical services to the community, the Ram Verma Award 2015 by the Cochin Royal Family, and Dr. Schwangans Memorial Oration 2015 in the 10th World Congress on Clinical Preventive Cardiology and Imaging. He's a brilliant orator. But far more important than that, I think, he has a mind that has a phenomenal blend of a researcher and a clinician at the same time. And that is what I love about him. I love his articles. I love his insight into the field. And every time I have a problem, I always have called him to take his advice. He is the adjunct professor to the Case Western Reserve University, Cleveland, USA, and also the adjunct faculty to the Department of Biotechnology, IIT Madras. So, Dr. Ajit Mullasari will be talking to us about the peculiarities and the challenges of heart failure management in India. Then we have the second speaker with us, Dr. John McMurray. Dr. John McMurray, I don't think requires any introduction to the cardiology and the physician fraternity across the globe. We know that he's a past president of Heart Failure of Association of ESC. He's a member of editorial board of several extremely reputed journals like New England Journal of Medicine, and sits on the editorial board of several other leading journals like European Heart Journal and Circulation. I've had a privilege to be sharing the dais with him in this pandemic. This is the fourth time I'm sharing the session with him. And every time we listen to him, it is an enlightenment. Let me tell you, he has crystalline thoughts. He has great insights into preventive cardiology, cardiovascular diseases in general, and heart failure in particular. He has lectured widely and won several awards, including Stokes Medal of Irish Cardiac Society and the 8th Arrigo Recordati International Prize for Scientific Research for outstanding contribution in secondary prevention and risk reduction strategies in patients with cardiovascular diseases. In 2013, he was named as one of the 400 most influential biomedical researchers in the world. And that, I think, you will come to know immediately when he starts speaking. His depth of thoughts, his clarity of speech, and his insight into what may lie in future for us is simply amazing. His primary research interests are heart failure, coronary heart disease, atrial fibrillation, and the cardiovascular consequences of diabetes and chronic kidney disease. He is currently the professor of medical cardiology and deputy director of Institute of Cardiovascular and Medical Sciences at the University of Glasgow, UK, and honorary consultant cardiologist at the Queen Elizabeth University Hospital, Glasgow. Thank you, Dr. Murray, for being here with us. We are privileged and honored to have you again with us to share your insight into the depths of management of heart failure with ARni. Thank you very much. Now I invite Dr. Ajit Mullasari to begin his speech. Thank you.
Can you hear me, Shekhar?
Yeah.
Loud and clear? Okay.
Loud and clear. Loud and clear.
So I didn't want to hold you back from Dr. McMurray. It's our privilege to have him here to speak. And so I thought I will restrict to some peculiarities of heart failure in India. As you know, heart failure is one of the biggest burdens of cardiovascular disease worldwide. And it's the cause of the largest expense for treatment of medical conditions in the United States. And in India, just as ischemic heart disease grows as the problem, which is a double whammy with infectious diseases, we have a problem of heart failure, which is increasing all over the country. Now, I just want to talk only simply a few minutes about some of the work which was published in the European Heart Journal of Failure by one of my colleagues, Hari Krishnan, in the European Heart Journal in 2015 of the Trivandrum Heart Failure Registry, which possibly is the most quoted heart failure registry in India. What is peculiar? It was about 1,200 patients from Kerala, basically in 13 urban and 5 rural centers, which was followed up for 3 years. about 71% of the patients had ischemic heart disease. So that is not peculiar in Kerala, because Kerala is one of the most, what I would say, advanced social indicators, lowest infant mortality rate, the lowest in the country, and it's almost on par with many of the European nations and American Western nations. So basically, they have a profile of patients which are typical of Westernized society. It is not similar in most parts of India. Anyway, 71% of the patients had ischemic heart disease. What was concerning was that 20% of the patients had guideline treatment for heart failure, number one. And that was a problem. The second problem was that the mortality was about 10% in hospital for heart failure, 9.7 to be exact, in patients with decreased ejection fraction, and about 5% in patients with preserved left ventricular function. Much higher than what is quoted in the Western literature for in hospital mortality. And what was more concerning was in 3 years, almost 50% of the patients died. And this is attributable to multiple issues. One is a poor guideline treatment. Number two, the access to healthcare, which even in an economically good state like Kerala, which has a very good governmental setup for heart failure management, you have this problem going on. And finally, I would put my point in that heart failure is underdiagnosed, just like all over the world, and more so in India. It is undertreated in most of India. The prevalence of heart failure is as much or more in India. The treatment guideline is very, very low, and it's less than 20% in the most advanced state for medical management in India. And I think if 50% of the people die in 3 years in a place where public systems are well preserved, I think it's a concern for most of heart failure in India. So these are the peculiarities. I didn't want to hold you back with slides, and I've not published anything major in heart failure. So I thought I'd rather ask Dr. McMurray to now talk, and maybe we will have the questions, which I think we all are interested in asking Dr. McMurray on heart failure. So I'll just hand it over to Dr. John McMurray to give his lecture on the key aspects of treatment of heart failure today and the issues which are worrying us and are also helping us, because there have been a lot of strides, especially ARni's, SGLT2 inhibitors, which have changed the profile of the treatment of patients with heart failure and have improved the outcomes. So Dr. McMurray?
Thank you very much, Dr. Mullasari. I hope I can get my screen to share. So let me see. Can you see my slides?
Yes, we can.
Yes, you can. Thank you very much. So thank you very much for inviting me to speak to you. Thank you very much indeed for the introduction. The person you described, I do not recognize, and I'm sorry if I will disappoint you, but I'll do my best not to. So I want to talk today specifically about sacubitril valsartan, and these are my disclosures. And I want to go back really to where we were probably at the start of this century, certainly at the start of the last decade. And we had, I think, very clearly established that the foundational therapy for patients with heart failure and reduced ejection fraction are these three treatments: a renin-angiotensin system blocker, a beta blocker, and a mineralocorticoid receptor antagonist, used together because we believe they all work in distinct ways. They work through distinct pathophysiological pathways. We believe that their benefits are additive and incremental. And as you can see from the names above each of these boxes on the slide, very robust evidence, multiple randomized trials confirming the life-saving benefits of these three therapies. And really what I want to do is I want to take you the next step forward, and the last of those treatments that was shown to improve survival for the first time was in 1999. And I want to fast forward to 2014, when we got the first evidence about the new treatment that I want to focus on today. And when I mention sacubitril/valsartan, it might be better to describe this as valsartan-sacubitril. And in fact, when we first started to use this drug, it was called LCZ-696. It didn't have any name, but it was a combination of two different treatments. And that's a fundamentally important thing to remember. This is a combination of two different treatments. One which you know well, which is an angiotensin receptor blocker, in this case valsartan, and the other which is something that most doctors didn't know about until fairly recently, and that is a neprilysin inhibitor or neutral N-peptidase inhibitor. Now, what is neprilysin inhibition about? Why did we want to test the value of neprilysin inhibition in patients with heart failure and reduced ejection fraction? Well, the reason for this, again, goes back a long time. In fact, goes back to the early 1980s. In fact, when I was a junior cardiology trainee, and was certainly personally extremely intrigued by the discovery that the heart, which until that point I thought was a pump, was in fact also an endocrine organ. And the heart, and then we learned the blood vessels, and then more recently we learned also the kidneys produce a family of peptides which act to protect the organism, protect the body, protect us from volume and pressure overloads. And when we have a high blood pressure, or when our circulation or our extracellular fluid volume is expanded, our heart secretes atrial and B-type natriuretic peptide. We now know that our blood vessels secrete C-type natriuretic peptide, and more recently the kidneys produce a different natriuretic peptide called urodilatin, which is actually very like ANP in structure. And these peptides you can think of as the body's own defense against that pressure and volume overload. They cause vasodilatation, they enhance sodium and water excretion by the kidneys, and what they also do, we now know, is to inhibit pathological growth. So they inhibit hypertrophy, they inhibit fibrosis. And since this is the way that the body tries to protect itself from pressure and volume overload, we thought, well, wouldn't it be great if we could enhance, if we could augment this protective mechanism, this endogenous protective mechanism, as a treatment for heart failure and perhaps other diseases. And that's where neprilysin inhibition comes in, because neprilysin is the enzyme that breaks down natriuretic peptides, and neprilysin is responsible for breaking down all of these peptides. Now, we've since learned that neprilysin also breaks down a lot of other peptides, and actually these may also be important in the way that neprilysin inhibition works. But the reason that this therapeutic strategy was developed was to augment the natriuretic peptide system. Now, it took us a very long time. In fact, it took 25 years to figure out how to do this for a number of different reasons. But one of them was that, as you can see in this slide, neprilysin also breaks down bradykinin. And we found out, unfortunately, that if you couple a neprilysin inhibitor and an ACE inhibitor, and both ACE and neprilysin break down bradykinin, if you block both of those enzymes at the same time, then you can cause an unacceptable rate of angioedema. And it wasn't until the development of angiotensin receptor blockers that we could figure out a safe way to couple neprilysin inhibition with renin-angiotensin system inhibition at the same time. In other words, by combining a neprilysin inhibitor with an angiotensin receptor blocker. So it took a long time to figure out how to use this therapeutic intervention. So I'm now going to cover with you a very short period of time, but a very, very busy period of time in terms of understanding, in terms of publications, in terms of studies, because as you can see here from this figure about publications related to neprilysin, you can see that in the past 5 or 6 years, there's been a huge increase in the number of those, and that's what I'm going to try and deal with in the next few minutes. And I'm basically going to focus on 3 very important clinical trials. 2 of these are in patients with heart failure and reduced ejection fraction. That's PARADIGM and PIONEER heart failure. 1 is in heart failure with preserved ejection fraction. And then I will try and finish up with by saying where I think we've got to in 2021. So let's start with the first of those trials, and that's the PARADIGM heart failure trial. And this was our pivotal breakthrough trial demonstrating the value of neprilysin inhibition. We published this in 2014, and this slide summarizes in a very simple way what the experiment was, what the hypothesis was, and the experiment that we carried out. And simply what we did was we compared using a neprilysin inhibitor in addition to those foundational, those core therapies that we knew are beneficial in heart failure. We compared the combination to just the foundational therapies by themselves. And of course, the neprilysin inhibitor RAS blocker combination was sacubitril valsartan in one arm of this trial. In the control arm, the RAS blocker was enalapril. We had to use enalapril because that is the regulatory gold standard. That is actually the only RAS blocker convincingly shown to reduce mortality in heart failure with reduced ejection fraction. So the primary outcome in the PARADIGM heart failure trial was the composite of cardiovascular death or heart failure hospitalization. And you can see in this slide that compared to conventional therapy, and adding a neprilysin inhibitor resulted in a 20% relative risk reduction. The hazard ratio is 0.80, so 20% relative risk reduction, highly statistically significant. And in fact, both of the components of that composite endpoint, cardiovascular death by itself, heart failure hospitalization by itself, each of those was reduced by approximately 20%. And this was a very striking, very statistically robust benefit. And as I said, the first breakthrough with a new treatment reducing mortality in this type of heart failure for 15 years. So we were very excited by this finding. There have been many, many publications from the PARADIGM heart failure database. But I think one of the most important ones is this from a couple of years ago. And what this study did was to look at all the various subgroups in the PARADIGM heart failure trial. So patients who had atrial fibrillation, patients with diabetes, patients who had chronic kidney disease, younger patients, older patients, and so on, looked at all of these subgroups. And what we did was, in this enormous study, we had 8,400 patients, we calculated the number of patients needed to treat to prevent one of them experiencing the primary composite endpoint. So how many people would you have to treat for 5 years to prevent one of them dying from a cardiovascular cause or being admitted to hospital with worsening heart failure? And no matter what subgroup we looked at, that number was somewhere in the range of 12 to 19, which is a very small number, indicating a very large absolute risk reduction. And if you prefer to look at all-cause mortality, then here is the number of patients you would need to treat for 5 years to prevent one patient dying from any cause, dying from all-cause mortality. And this figure shows you all the other treatments that we have as well. Drug therapies such as beta blockers and MRAs, device therapies like ICDs and CRT. And there are two numbers here for an angiotensin receptor neprilysin inhibitor. One is for the head-to-head comparison that we did with an ACE inhibitor. That's a number needed to treat of only 21. But in fact, if you were to start therapy with sacubitril valsartan, so instead of starting with an ACE inhibitor and switching to sacubitril valsartan, if you started treatment with sacubitril valsartan, the number of patients you would need to treat for 5 years to prevent one of them dying, that number needs to treat is only 11. That is a very small number needed to treat. That is a very impressive absolute risk reduction. So the benefits of neprilysin inhibition are really very substantial indeed. And in fact, as you will see later this year, when the new guidelines come out, you will see that sacubitril valsartan really has moved to center stage as one of now our foundational therapies in heart failure with reduced ejection fraction. And I think most of us, we've had the opportunity in Glasgow to be able to use sacubitril valsartan for about 5 years now, as has been the case in the United States. And I don't think any of us today would ever start a patient on an ACE inhibitor or angiotensin receptor blocker as first-line therapy. We would start them on sacubitril valsartan because they're getting 2 treatments in 1 pill. They're getting a much larger benefit with that combination than they're getting with an ACE inhibitor or angiotensin receptor blocker by itself. Now, of course, with any trial, no matter how large, no matter how good, there are always criticisms and there are always remaining gaps in evidence. And when we presented Paradigm Heart Failure, there were several criticisms and there were several gaps in evidence that were highlighted. So when we did our trial, we took patients who were already on a RAS blocker, and we randomized them basically to continue on an ACE inhibitor or to switch to sacubitril valsartan. In Paradigm, we did not start newly diagnosed patients who'd never been treated with a RAS blocker on sacubitril valsartan, so there was a gap in evidence. We only studied ambulatory patients, so patients in the outpatient setting. We did not study hospitalized inpatients, in other words. We had relatively few African Americans, although that's maybe not such a relevant issue for our discussions today. We had a run-in period for reasons we can discuss later if you wish, but we had to have that because of the regulatory review of the design of the study when we had those discussions. And during that run-in period, all patients had to tolerate both full dose enalapril and full dose sacubitril valsartan before they could be randomized. So there were these issues, and that is why a more recent study published in 2019 called the Pioneer Heart Failure Study is so important, because it fills most of those gaps. It addresses most of those remaining questions. So this is the design of Pioneer Heart Failure. Again, there's a 1-to-1 double-blind randomization to sacubitril valsartan or enalapril. But this trial was done in patients who had been hospitalized with decompensated heart failure. So this was done in inpatients, not outpatients. You can see the design characteristics here on the left of the slide. There was no run-in period. Patients were not required to be on an ACE inhibitor or an angiotensin receptor blocker. So again, this trial dealt with some of those issues that remained following PARADIGM. This was a much smaller study, and it was shorter term follow-up. So it was only 8 weeks of randomized therapy. The reason for that, it was thought to be unethical to randomize patients to remain on an enalapril longer than 8 weeks, because really by 8 weeks, these patients were becoming PARADIGM heart failure like patients. And we knew by that stage that these patients would clearly be better off. They would be more likely to live if they were on sacubitril valsartan. So it was considered unethical for patients to remain on enalapril for more than 8 weeks. So this study had a relatively short period of randomized double-blind comparative treatment. These are the patients who were randomized in Pioneer. As you can see, it was around 900 patients. About a third of the patients were of African descent. So again, that issue was addressed. As you can see here, about a third of patients had no prior diagnosis of heart failure. So the issue about not having de novo patients was addressed. About half the patients had no previous treatment with an ACE inhibitor or angiotensin receptor blocker. So again, that other concern that remained after PARADIGM was also addressed by the patients who were enrolled in Pioneer Heart Failure. The primary endpoint, because this was a relatively small, relatively short-term study, was reduction in NT-proBNP. We know that this is a very good surrogate. This is the inactive peptide. This is simply reflective of left ventricular filling pressure and wall stress. We know that it is an excellent surrogate endpoint for morbidity and mortality in HFrEF. So this was the primary endpoint, and you can see that within 1 week, we didn't know this before Pioneer, that the effect was so early, but you can see here that within just 1 week of treatment, there was a significant reduction in NT-proBNP, and that reduction was sustained over the course of the randomized treatment period. But very importantly, this reduction in NT-proBNP was seen despite the fact that only just over half of patients were on the target dose of sacubitril valsartan. So again, if you remember, one of the critiques of PARADIGM was that everybody had to tolerate full dose sacubitril valsartan before randomization. Here you can see the effect of lower doses of sacubitril valsartan, at least on this biomarker surrogate endpoint. And again, even in these hospitalized, recently decompensated heart failure, very good tolerability. Really the only difference, and we know that this is the difference, is more hypotension with sacubitril valsartan compared to enalapril. But the really surprising, the really important finding is shown in this figure. So the investigators in Pioneer pre-specified a composite morbidity mortality endpoint. And the components of this were death, readmission to hospital again with worsening heart failure, implantation of the left ventricular assist device, or listing for heart transplantation. Now, in fact, this endpoint was driven predominantly by heart failure readmission. There were not many deaths, and there were virtually no transplant listings or ventricular assist devices implanted, because remember, this was about 900 patients who were randomized for only 8 weeks of treatment. But look at this, there was again, remarkably, a statistically significant 46% relative risk reduction in this composite outcome. As I said, statistically significant, a very small number needed to treat. Remember, this is only 8 weeks, 56 days of follow-up. Now, normally, I would be a little bit suspicious of this. Small numbers, short-term treatment. I wouldn't necessarily believe that this was true. I might be concerned that this reflected the play of chance, except to say that if you go back to the PARADIGM trial, we actually saw that within just 30 days of randomization, as you can see here, there was a statistically significant reduction in cardiovascular death or heart failure hospitalization that was sustained throughout the remainder of the trial. So I don't think this is a fluke, because we've seen it in 2 trials. We've seen this very early benefit with this therapy. So neprilysin inhibition is not only effective, but it is effective very quickly after you start patients on treatment. And that is crucially important. You heard earlier some of the terrible statistics about survival in India from heart failure. Here's a treatment, a new treatment that adds more than the treatments we already have available and works very quickly indeed. Can be given, as you've seen, in outpatients, and also can be started in hospital safely and effectively. So really, the Pioneer heart failure study addressed all of these remaining concerns and gaps in evidence. Now, another, and of course also addressed the issue about NYJ class, because of course most of these patients were in class 3, 4 when randomized. Another criticism we had after PARADIGM was that we had not looked at changes in cardiac structure and function. Some of my colleagues in the US did this recently, and here you can see again, compared to enalapril, reductions in left ventricular end diastolic, and then systolic volume reduction in left atrial volume as well, with sacubitril valsartan compared to enalapril. And actually, to my great surprise, these changes were apparent very early on. We don't normally see, I would usually tell patients, and when I do trials, I'm not expecting to see major remodeling for 6 to 9 months after starting treatment, but this was discernible within just 12 weeks of starting treatment. So it's not a surprise, it's very consistent with those large clinical benefits and early clinical benefits that I mentioned, but it's nice confirmatory findings, again, filling another gap. So I'd now like to change completely, switch gears and talk about the other major heart failure phenotype, which is heart failure with preserved ejection fraction. And we did do another large trial in patients with HFpEF. It was called Paragon heart failure. It was our sister trial to Paradigm. We published this in 2019. And in Paragon, we compared sacubitril valsartan to valsartan. We didn't have to use enalapril in this study because there was no mandate in patients with HFpEF to use enalapril. The guidelines do not recommend ACE inhibitors, do not give ACE inhibitors a class 1 level A recommendation in HFpEF, unlike HFrEF. So we were able to do a more pharmacologically sort of direct comparison, sacubitril valsartan compared with valsartan. So this was our primary endpoint, cardiovascular death and heart failure hospitalization, this time looking not just at time to first heart failure hospitalization, but looking at all heart failure hospitalizations. And as you can see here, sadly, although there was a 13% relative risk reduction, the upper 95% confidence interval was just above 1. In other words, the p-value was just over 0.05. It was 0.0587, 0.059. So this finding was not statistically significant overall. And here is the breakdown of that composite outcome. In these patients, the major morbidity, mortality component is heart failure hospitalization. Cardiovascular death is relatively uncommon. If you look at the valsartan column, if you look at heart failure hospitalizations, the rate per 100 person years is 11.6 for heart failure hospitalization compared to only 3.1 for cardiovascular death. So the major problem in patients with HFpEF is heart failure hospitalization. That was reduced by 15%, the hazard ratio was 0.85, but once again, the p-value was not statistically significant. It was borderline 0.056. Now, in fact, we had pre-specified an exploratory endpoint where, in addition to heart failure hospitalization, we included urgent heart failure visits. So, for example, visits to the emergency department where patients received intravenous therapy for worsening heart failure. When we looked at this endpoint, as you can see, the treatment effect size was pretty much the same. Hazard ratio was 0.86, so a 14% relative risk reduction. But with the additional numbers of events, you can see that the p-value this time was just on the right side of 0.05. It was just nominally statistically significant at 0.04. So in other words, overall in this study, there was a modest benefit. It was of borderline statistical significance, but not nearly as clear-cut as in patients with heart failure and reduced ejection fraction. But we did find one very interesting additional finding, and that was in our pre-specified subgroup analyses. One of those that we looked at, which was ejection fraction, you can see that when we took patients who had an ejection fraction at or below the median value of 57%, these patients seem to get much more benefit from sacubitril valsartan than patients with a more normal ejection fraction. And in fact, if you look at this in a different way, this figure shows you a hazard ratio, that's the solid blue line, as a continuous measurement. So, or in fact, it's not a hazard ratio, it's a rate ratio. You can see that up to an ejection fraction of about 60%, the rate ratio is below 1, so in keeping with benefits from sacubitril valsartan, but there's no benefit above an ejection fraction of about 60%. Now, again, we're normally suspicious of subgroup analyses, but we think there may be something in this one, because when we went back and we looked at our older studies, the CHARM program, where we had patients with an ejection fraction covering the whole range, when we went back and we put the 3 MRA trials with spironolactone and eplerenone in patients with HFpEF and HFrEF, when we put all of those trials together, you can see that with candesartan and with mineralocorticoid receptor antagonists, you see something very similar to what we see with sacubitril valsartan. We're seeing benefits with these drugs that work in patients who've got clearly reduced ejection fraction. We're seeing these benefits apparently extending to a higher ejection fraction than we previously considered these drugs indicated for. In other words, it looks like these treatments are beneficial in patients with ejection fractions perhaps in the range of something like 40 to 55 or 60%. And as you know, this is consistent with the most recent ESC heart failure guidelines, which introduced the heart failure phenotype, heart failure with mid-range MR, mid-range ejection fraction, although we will be renaming that to become heart failure with mildly reduced ejection fraction. And the reason for that is what I've just shown you suggests very strongly that patients with so-called heart failure and mildly reduced ejection fraction really have heart failure with reduced left ventricular systolic dysfunction. These patients with an ejection fraction that is below normal but not clearly reduced, these patients seem to be getting benefit from drugs that we know work in patients with an ejection fraction below 40%. Now, just to finish off with, I'm going to mention that actually last month, in between their 2 meetings to look at the new vaccines, the Pfizer and the Moderna vaccine for coronavirus, the FDA also held 2 public advisory committees on heart failure with preserved ejection fraction. One of these was about sacubitril valsartan. We presented the data that I've just shown you, and the US Food and Drug Administration asked this advisory committee to vote on whether they thought, in the light of the data that I've just shown you, whether there should be an indication for sacubitril valsartan in some patients with HFpEF. You can see here that the committee voted 12 votes to 1 in favor of recommending sacubitril valsartan. And I can tell you from that discussion, the recommendation was to use it in those patients who have an ejection fraction that is below normal, maybe 55%, maybe 60%, but not clearly reduced. So there may be, the FDA is going to, we believe, decide this month what they will do about this advice they got from the committee, but we think that they will probably give a new indication for sacubitril valsartan, not just in HFrEF, but for at least some patients with HFpEF as well. So to finish with, where are we in 2021? Well, since Paradigm Heart Failure, there have been a lot of new trials. In fact, as you can see here, there have been 4 new trials in ambulatory patients, outpatients with chronic heart failure. And of course, 2 of these that have attracted a lot of attention are the new trials with SGLT2 inhibitors, which also now clearly have a role in treating patients with heart failure and reduced ejection fraction. And what the new guideline committees have been reviewing and considering and thinking about is all of this new evidence, because in fact there have now been 5 different drugs in the past 10 years roughly that have been tested on top of those 3 foundational therapies that I mentioned right at the start of my presentation. Only 2 of these are life-saving treatments. I just talked about one of them, which is neprilysin inhibition, and of course we mustn't forget SGLT2 inhibitors as well. So the new guidelines are going to clearly state that the really important treatments going forward in 2021 are what we've called, for ease of remembering, the 5 alive. So the 5 pharmacological treatments that save lives, shown at the bottom here, the pillars of everything else that we should do for these patients. The 5 alive are these pharmacological interventions, which of course we can give in 4 pills, because sacubitril/valsartan is 2 of these 5 treatments in a single tablet, 2 life-saving treatments in 1 pill. So to summarize and to conclude, these are what people often ask me: who should we give this to? When should we do it? How should we do it? Well, it's very simple. We should be giving sacubitril/valsartan to all of our patients with heart failure and reduced ejection fraction. It may go further than that from next month, depending what the US Food and Drug Administration recommends. When should you do it? Definitely as soon as possible. The drug works quickly. It's actually much easier to use in newly presenting patients. So it's better to start with it than start with an ACE inhibitor and try and switch over, and use it in the same way that you would use any other neurohumoral blocker, the same way as you would use an ARB or an ACE inhibitor or a mineralocorticoid receptor antagonist. You need to watch blood pressure, you need to check renal function, you need to watch potassium, although in fact there is less decline in kidney function with sacubitril/valsartan than with enalapril. Neprilysin inhibition also protects the kidneys. So I'm going to stop there. If you're interested in knowing more about this, then late last year, as you can see here, the JACC Heart Failure published a whole issue dedicated to sacubitril/valsartan, reviewing all that we've learned about this new treatment in the 5 years that some of us have been able to use it. So if you want to know more, this is a beautiful summary, state-of-the-art journal issue with a state-of-the-art review explaining everything that we've learned about neprilysin inhibition over the past 5 years that we've had it in our hands to treat our patients. Thank you very much.
McMurray, this was again, as usual, one of the most crystalline and clear-cut messages about what has transpired from the Paradigm-HF, Pioneer-HF, and the Paragon-HF trials. And now I think we should be taking the questions from the audience, unless Ajit has something to add right now. Ajit?
I think we'll discuss it with the audience and then go on with the issues which I think we can discuss it further on. Shekhar? I think we've lost Shekhar, so maybe we can start with a question to Dr. McMurray today. I think I was glad to be on this.
Of acute myocardial infarction.
Yeah, Shekhar,
What is the
we lost you for a minute. Please repeat that.
Sorry. What is the place of ARni in treatment of acute heart failure in the setting of acute myocardial infarction?
Great question, and watch this space, because in fact we have a new trial that should complete this year, 2021, called PARAGON-HF, where we've been comparing sacubitril valsartan to ramipril in patients with left ventricular systolic dysfunction or transient pulmonary edema complicating their myocardial infarction. So we don't know at the moment, but we will know very, very soon. By the end of this year, that trial will be complete and we will have a result.
Sure. So till that time, wouldn't recommend to use this molecule in the acute heart failure, decompensated heart failure in the setting of acute MI? Is that
well? We haven't been doing, and I personally haven't been doing. I'm, as you know by now, very evidence driven, and I prefer to wait for trials. I mean, you know, if I have a patient who comes back to me a month after they've been in coronary care and has remaining systolic dysfunction and is symptomatic, I'll treat them then, because in my mind that patient has transitioned from being what I would call a PARADISE-MI trial, that's our acute MI study, a PARADISE-MI patient, to becoming a paradigm heart failure patient. So then I'm comfortable, but in the acute setting in the coronary care unit, 48 hours after the myocardial infarction, I think I would wait until I see the results of the trial.
Thank you very much for that. But isn't it true that the pioneer analysis has shown that the de novo heart failure patients get more rapid decrease in NT-proBNP, and they are able to achieve the targeted dosages of ARni much earlier than patients with prior heart failure? Isn't it correct?
And I sort of did say that. I didn't review the data, but I did mention it's actually easier to use this drug in patients who present de novo. And actually, it's not just Pioneer. So that was the inpatient setting, but there's another trial called Transition that shows that as well. So there's no question it's easier to use this therapy in a newly presenting patient, because often what happens is if they've gone through ACE inhibitor, beta blocker, MRA, their blood pressure's got quite low, their kidney function's got a bit worse, and it's just more difficult to start sacubitril valsartan. Whereas if you get them new, when their kidney function's well preserved, when their blood pressure is a bit higher, they're very volume expanded, congested, it's very easy to use sacubitril valsartan then. And as you say, I mean, you get a very dramatic fall in sacubitril valsartan. In fact, I saw a patient this morning who left my hospital ward in December. I saw him in the outpatient clinic today, and his NT-proBNP was under half what it was less than a month ago, following the introduction of sacubitril valsartan.
Thank you for that insight. The other question which is commonly asked, and which is asked today also by one of the delegates, and I think Ajit, you can throw some light on that. In HFrEF patients management, chronic HFrEF patients, which one first, ARni first or a DAPA first, a SGLT2 inhibitor first, and why? Why? He wants to know why. And then the third sub question of that, the bigger question is, in which subgroup of patients with HFrEF will you be comfortable to start, or forced to start rather, an SGLT2 inhibitor upfront than ARni?
So I honestly would be happy, and personally do start either of those two treatments first. And the reason I do that is because they both have a very rapid onset of action. So that's important. I know that I'm getting that protection on board very quickly. I suppose the things that make me go one direction rather than the other is if somebody's got a relatively high blood pressure, then definitely sacubitril valsartan, because it lowers blood pressure. SGLT2 inhibitors have minimal effect on blood pressure, which is good for some patients, But if you want to lower blood pressure, then it's not so helpful. If the patient is congested, fluid overloaded, then maybe an SGLT2 inhibitor first, because they have this modest initial diuretic effect. So I'd be happy with either or. Truthfully, we don't know. You always ask the smartest questions, because I can tell you that I know of about 5 articles that will be coming out in the big cardiology journals over the next month or two, just talking about this very issue, because we're all debating, discussing, trying to think of the arguments, trying to work out what's best. I mean, myself and Milton Packer wrote something recently suggesting maybe even starting a beta blocker as one of the first treatments. So I think it very much depends on the patient and the setting. I'm probably not going to start a beta blocker first in a recently decompensated patient on the ward. So I think the patient characteristics will probably be what drives which you use first. I mean, obviously, if the patient's a diabetic, then an SGLT2 inhibitor is clearly the right thing to go with, because you're dealing with 2 problems with one therapy. But truthfully, the goal, and I think what you will see is a consensus around this point, the goal is to try and get as many treatments on board as quickly as possible. And I think we've all sort of woken up and realized very late in the day, our oncology friends are all telling us how urgent it is to diagnose cancer and to treat cancer, and everything needs to be done quickly. And we've not had that sense of urgency about heart failure. But you heard in the first presentation, I mean, these people have a mortality that is as high as most forms of cancer. But we haven't had that sense that we have to get these life-saving treatments started as quickly as possible. So I would say the more important question is not which of them in what order, but how do you get them all started as quickly as possible? How do you get them on board as fast as you can? And there, I think we've been much too cautious in the past, and we probably need to think about how we can expedite, speed up the introduction of these therapies.
Yeah, Ajit, what is your take on this question?
I think that this question is, as Dr. McMurray said, a very important question. We don't have studies which says what first. We've always discussed this beta blocker or ACE inhibitor first in chronic heart failure for a long time. But now we are coming to these 2 drugs and saying ARni or SGLT2 inhibitors. And I agree. If the patient is fluid overloaded, I take SGLT2, it's diuretic. Diabetic, I use SGLT2. Higher blood pressure, I use ARnis first. Unfortunately, both of them in acute heart failure in the ICU have no data, so I don't use them there. Maybe a day or 2 later will be okay to use any of these drugs. And I think it's going to be, like Dr. McMurray said, a combination therapy quickly in heart failure and get them fast in so that patients get the maximum benefit.
Yeah, I mean, I think maybe one thing to make clear is I don't think you're going to see in any of this new guidance, this discussion, you're not going to see any mention of ever starting with just an ACE inhibitor or ARB. That's just no longer on the table. If you really want to get everybody on all of these life-saving treatments as quickly as possible, you have to go with an ARni first of all. Might not be the first drug you use, but you're not going to use an ACE inhibitor before you use an ARni. When you use an ARni, it's 2 treatments in one. You're 2 of the 5. You're almost halfway there. So just starting with an ACE inhibitor, I think, is out of the question. Now, I realize I can say that I've got the luxury of working in the National Health Service that pays for the patient's drugs, and I totally understand in India, you know, I'm talking from my ivory tower, from a relatively well-off country that doesn't feel like that all the time. and I realize it might not be so simple, and that what I've talked about might not be possible for everybody in India, but I think that's the way we're thinking about it in Europe and North America, at least.
Yeah. Ajit and John, why this question keeps on coming again and again. When we talk about the paradigm, ARni trials, they were optimally treated patients with beta blocker, MRAs, and ACE inhibitors. And then ARni showed an incremental benefit by 25% approximately risk reduction in cardiovascular death and heart failure hospitalizations. When you talk of DAPA and EMPEROR trials, they were optimally treated patients with the same drugs. 10% were on ARni in the DAPA trial, and around 20% were on ARni in the EMPEROR reduced trial. And yet, these two molecules have shown an incremental benefit whether the patient were on ARni or not on ARni. And therefore, a lot of people have tended to believe that SGLT2 inhibitors could be a shade better than ARni in risk reduction. And that question haunts their minds. So I think what you're told is very correct. It is better to get as many drugs as possible on the board to reduce the risk reduction. I have one question. Let me say I put the patient on ARni and the blood pressure has come down to around 100 systolic. I'm not able to up-titrate ARni any further because of the borderline blood pressure or maybe because of prohibitive hyperkalemia. In this patient, wouldn't you go ahead and add an SGLT2 inhibitor as an add-on therapy?
Yes, I would, because although I would like to get to the full dose of sacubitril valsartan, sometimes it's not possible. I know that from my own practice, but I have to say I'm much happier than I used to be following the results of Pioneer, because in Pioneer only about I think it was 55% of patients were on full dose sacubitril valsartan, but there was still that clear reduction in natriuretic peptides, and indeed that reduction in clinical events. So that's telling me that even a lower dose of sacubitril valsartan has some benefit. And I would get them on an ARni. The reason I would get them on an SGLT2 inhibitor. The reason I would do that is because, at least in DAPA-HF, we found that there is a reduction in the risk of hyperkalemia with dapagliflozin. So if the patient has a problem with hyperkalemia, which is pretty rare with sacubitril valsartan, but if they did have it, then an SGLT2 inhibitor might actually help with that. And also, if the patient then gets better overall, if they improve more generally, and I don't know if you saw in November, but two studies, one from our group, one from New York, showing very impressive favorable left ventricular remodeling with empagliflozin. Both of the studies were empagliflozin. It may be that after being on an SGLT2 inhibitor for a period of time, the patient may have improved enough to then tolerate an increase in their dose of sacubitril valsartan. That's what we often see, that if you can make somebody a bit better as their ventricular function improves, their blood pressure will often go up a bit, and they may be able to tolerate a bit more of the other treatments that we want to get them on.
Yeah. Dr. Ajit, this question goes to you. Yeah. What would be your take on use of ARni in HFmrEF patients who are on hemodialysis? Hemodialyzed patients with heart failure with reduced ejection fraction. This is a question by Dr. So it's a very important question, really, indeed, because we are seeing lot of cardiorenal syndromes these days, lots of them. My hospital is, in fact, there is a literal epidemic of these cardiorenal issues in patients with hypertension, diabetes, old MI, now CKD, ejection fraction somewhere between 25 to 45 and needing hemodialysis. So what do we do about them?
Well, I don't think that once you're in hemodialysis, the issues of, potassium issues are really covered. So I don't think that we need to worry too much. I think, though, the specific area. I don't think there's any specific data on this, but I use it very liberally in these patients too, because I'm not really worried about renal functions. I'm not worried about potassium anymore. I'm just worried about the ventricle. I'm worried about his heart failure. And so I think this drug will be very good in that group of patients. I have no hesitancy as long as I keep a watch on the potassium on the regular follow-up. Another question, just to the previous answer which John said, why I use SGLT2 on because these two are different mechanistic drugs, and SGLT2 has a great effect on interstitial edema, which I think we don't have data with the ARNIs, and the ARNIs have great other remodeling ways. So when you combine it, you get more heart failure reduction and improvement of blood pressure. So I think it's great to combine these drugs when you're using it for heart failure.
Sure.
Okay.
Another question which is always there, that reduction of sudden cardiac death with ARNI. And this has always interested me. There was an article which said that patients who are on an ICD with HFmrEF, and you use ARNI on them, the number of shocks the patients received who were on ARNI were far much lesser than the patients who were not on ARNI. So does ARNIs have any electrical remodeling kind of an effect in reduction of sudden cardiac death in patients with HFmrEF? That is my first question. There was
First
also
question.
a paper.
Well, can we do the first one? So, well, I don't even know what electrical remodeling means. That's too clever for me. So first of all, sacubitril valsartan definitely reduces sudden death significantly. We've published on that. Sacubitril valsartan reduces sudden death even in patients who've got an ICD implanted. We've published on that. Very interestingly, and I'm embarrassed almost to say this because it's now 6 years after the event, but very recently we went back through all the data that we had about ventricular arrhythmias, and it reduces ventricular arrhythmias. I suppose that's no great surprise, but I can't imagine how we were stupid enough not to actually sort of, I thought we'd done every analysis you could conceivably do of the Paradigm Heart Failure database, but one of my very smart new research fellows went, looked, found all of this information, and we've been looking at that. There's definitely a reduction in ventricular arrhythmias. So if that means ventricular remodeling, then electrical remodeling, then yes. But I like to think, I like to see reduction in ventricular arrhythmias, that's good. But what I really like to see is reduction in sudden death. And actually, most importantly of all, I like to see a reduction in all-cause mortality, because all of those things, they're like in a chain of events. And if you don't see all of them, you have to always wonder. I can reduce ventricular arrhythmias with amiodarone, but I can't reduce mortality. So I think the more important thing is that we have, beyond any question of doubt whatsoever, shown a reduction in sudden death with sacubitril valsartan. Sorry, you had a second question, I think.
Yeah. This is for both of you. There was a paper which I'm sure Ajit must have come through. A case, not a paper actually, it's a case report of 3 cases from one cardiologist group in Maharashtra state. 2 patients had left bundle branch block, were scheduled to have a CRT, and they started them on sacubitril valsartan. Patient stabilized very well. So CRT took a back seat, and around 6 months after sacubitril valsartan 100 milligram BID dose, in both these patients, the left bundle branch block disappeared. It was not rate-related left bundle branch block. The rates of the left bundle, heart rate, when they showed they had a LVBB in the initial was around 89 beats a minute, and after 6 months of therapy were around 82 beats per minute. So there was not much of a difference in the heart rate, but the LVBB had disappeared. And the third patient had a diffuse intraventricular conduction disturbance where the QRS complex narrowed by almost 45 milliseconds in 6 months. The QRS complex became from 160 milliseconds to 115 milliseconds over 6 months period. What is your take on this with ARNI?
I think these are case reports, but I'm not surprised. I think what the drug does, and this is typical in Indian practice, that you have patients who come in who have LV dysfunction, who are, we're treated medically with everything, and now, you have this ICD consideration on these patients because their EFs are less than 35, and you're telling these patients all this, that you need to get an ICD maybe to prevent sudden cardiac deaths, and then you had this drug ARni which suddenly came on the horizon, and then you shifted them to this, and then the ejection fraction improved despite they being optimally on some other drugs, and they start looking better. The QRSs get narrower, and I think that I particularly have seen a few patients who were also who were slated for CRTD, and the QRS narrowed, and I think I was fortunately didn't get the CRTD in the patient because of the costs. Patients just waited because they didn't have money, and it was good for them because they didn't get an unnecessary CRTD because the QRS is narrowed and the functions improved. So I think this will change that area, I think, where we may not, that's a very small group of patients, but we may not need to have these CRTDs very quickly put in, and maybe this 45 days waiting and then putting the CRTD may go away. And I think it's a good study too in India, because not patients cannot afford it. And so if you follow these up patients with ARni and then do a randomized group of patients who got the CRTD and didn't get the CRTD and follow them up nicely over some period of time, we could sort of prove a point that patient didn't get it and still did as well as the other group of patients.
Yeah, but Ajit, now that ARni has gone off patent, and we are now some like drugs like Zayo available at maybe 1/4 of the cost, do you think the use of ARni would increase in this country in HFrEF patients? At least those who deserve the drug will get the drug and stay with the drug, and not that the main problem of non-adherence, as far as I see, was the cost initially. Now the cost has come down remarkably and will keep on coming down in future. So do you think we will be able to treat many more patients with ARni in future to come?
Yeah, I think you're right, Shekhar, because our problem always has been cost for patients. And I think one good part of India has been the development of pharmaceutical industry. You see it with the vaccine industry. Most of the vaccines are going to be supplied from India. So I think that this is something we need to be proud of. And I think once the patents are down, I think all patients will get ARni, at least in the middle class group and the richer group. The poorer group, as the cost comes down, we're going to give it to all of them. And slowly it will be available on the government, the government list of drugs. It's just a question of when. And I think more of us will use this drug, prolifically, and I think it'll completely replace ACE and ARBs, in my opinion.
But Dr. John, as I understand, even in the Western world and your world, the penetration of ARni in HFrEF patients is not as much as we expected it to be. Maybe 1 in 3 patients of HFrEF may be getting ARni. Am I correct if I say so?
Maybe more like 1 in 2 now, but yes, one in 3.
Yeah. What are the reasons for that? What is the reason for that? Is it the cost or the insurance coverage?
Cost. The drug was ridiculously priced, astronomically expensive, even for our national health services, and as a result, the payers put up barriers to the use of the drug. So it's taken a long time. But now in Western Europe and North America, it's more like it's getting close to 1 in 2, at least in our new trials. Patients are receiving it, but it's still very low rates of use in other regions of the world where the expense is the issue. In fact, it's very interesting. ARNIs and ICDs pretty much reflect the use of each of those. The geographical distribution is very, very similar, whereas something like spironolactone, which is very inexpensive and very effective, is used in countries that don't have a lot of money. So it's fascinating. In the US, very high rate of use of ICDs, very high rate of use of ARNIs, very low rate of use of spironolactone. Latin America, it's the opposite. It's very, 80% of patients on spironolactone, but hardly any have an ICD or have got sacubital valsartan. So economics really matter.
Yeah, but is it? See, for example, now let me tell you the good news in India. We have now got ARni off patent. We have got now dapagliflozin off patent, and we have got rivaroxaban off patent. So we can have a lot of population which is satisfying the eligibility criteria of compassing the typical antithrombotic therapy of aspirin with 2.5 BD of rivaroxaban. We will have a lot of patients being prescribed dapagliflozin. Question is, yet in my country, despite the cost being one barrier, there's another clinical barrier, which is clinical inertia on part of the physicians and even the cardiologists to embrace these therapies in their routine clinical practice. Do you have any suggestions, you and Ajit both, do you have any suggestions how we can overcome this clinical inertia?
Well, let me put we work with STEMI a lot in India, and forget about, all these expensive drugs like aspirin and clopidogrel and statins, which are pretty, very affordable, and it's on the government list of patients. There is tremendous, both physician and patient inertia of taking these drugs. And I think this is basically partly education, partly regulatory issues, but you've never been pushed by the Indian authorities on regulation whether if you don't give this drug, are you liable for not giving this drug? So, things like a follow-up tick on what drugs are prescribed at discharge, what drugs is prescribed on 1 month. These we proved was very clearly what was important to push the physicians to use the drug. And then the patient, though he has access, again, this is an issue. It's not that many in India, in south of India especially, have access to all these drugs from the government at no cost, zero cost. You can go and get these drugs at zero cost from the governmental dispensaries and stuff like that. It's just that patients don't do it because they just, they don't think that this is important because they don't know, or simply they don't put health as a priority and they think that something else is more a priority than health. So I think that these are issues which are inherent. Alternative therapies are a big issue. And I think that we need to educate patients because they use alternative therapies very often in south of India. To prevent a lot of things. So I think these things have to be drilled into patients and drilled into hospitals, and unless there's some regulation both ways, I don't think this is going to get solved. And I'm sure this happens even in the US. If you look at the randomized trials, you'll see much better, much better usage. But you go to the registries, you'll find the same problems even in Western Europe and US.
No question. You're absolutely right. I mean, I suppose I agree with everything that you said. And I suppose the only other thing is for us sometimes to think it's a good idea to think about every patient as a member of your family or yourself. How would you like to be treated? Because there is a little bit of inertia that's about the extra effort of having to write another prescription, maybe to arrange a follow-up visit, to have to check electrolytes. It's a bit more work. Human nature is that we don't necessarily go out and seek to make our own lives more difficult, more complicated. So that, and then I think globally, one of the points that Ajit mentioned was, patient empowerment, patients learning, patients taking not just responsibility, but trying to learn about their health, learn about treatment, knowing what they should be getting. It really, I'd like to see more of that. Even in our country, I'm sometimes very disappointed by how patients don't take a more active role in managing their own condition. I have to run, I'm afraid, because I'm already late for another meeting, if that's okay.
Absolutely.
Very, very good to speak to you again. And thanks, as always, for the very nice introduction, which I don't deserve.
Thank you.
Dr. Joshi.
Bye-bye.
You are muted, sir. Yeah.
Yeah. Dr. Ponde, would you like to ask any question to Dr. Mullasari?
I have one more question, Ajit, here which is a very common practical question. The question is, if I have a patient with a blood pressure of 90 systolic, what dose of ARni I should start with, and what
Well,
precautions I should take?
yeah, well, we were part of both the Paradigm and Paragon, both of the trials. One of the issues which I realized that the starting dose in many of those trials was 50 milligram twice a day, was the drop in blood pressure in Indian patients, especially the low weight patients. So they seem to drop their blood pressures a bit more than when they have borderline blood pressures. So if they have borderline pressures, I think it makes sense to start at 25 milligram twice a day, especially in the low weight patients, and then gradually push it up. And as the heart failure gets better treated, the blood pressure comes up. So, I think that it's as you go up, you follow these up weekly, and then you see that the pressures are getting better. And then you can generally push the drug up further. And as you push the drug further, you remove the diuretic. So again, the blood pressure improves because this drug is great for, helping that too. And then I slowly tried to pull off the drugs like Lasix and stuff like that once we have the MRAs and the SGLT2s on board.
Yeah, Ajit, but one question which I was discussing with the John Cleland, also the European Heart Failure Association president last year in CSI, which Praful organized. Is it sensible? I mean, we always have to down titrate the diuretic when you push up ARni. But when the patient is on carvedilol, can shifting from carvedilol to bisoprolol like drug, which doesn't cause much of a drop in blood pressure, will help?
Well, I think this question again, which beta blocker is better, is more of, for example, if you use Europe, it's many of the trials come with bisoprolol. Yeah. You go to the US, it's carvedilol. So it's a very difficult question to say head to head between these two good drugs, which is better, which is not better. But, I agree, because of its alpha blocking effects, carvedilol may have some issues with blood pressure more than bisoprolol. But again, we don't have head to head with these two drugs in these heart failure patients. So before we say, oh, this is better and that is better, I think it's important that we have some studies. I think both are great drugs and you can use any of these.
Ajit, one more question from Dr. Dhiren from Mumbai. He says that we have already 5 pillars in HFmrEF. How many more pillars are likely in the next 4 years? That is what his question is. How many more pillars are likely to come?
Well, what we have to understand is, despite all these beautiful drugs which have come in heart failure, the residual mortality and residual readmissions is pretty high. So it's not that we have conquered heart failure with all these drugs. So I think that we are just starting the fight against heart failure. I think the other drugs like vericiguat, even the drugs like ababrodine, maybe newer drugs which will come in for heart failure, which we're going to see soon. I think they will add some more data on improvement. And I think that just like many of the treatments like STEMI and stuff like that, where we got a handle on things and brought mortality down to single-digit numbers, less than 5% in most patients of STEMI, I think we should be getting heart failure down if you start treatment early and before the vicious cycle of damage and remodeling loss is done. I think we should await a lot of these newer drugs on top of these 5 pillars. It's just a question of time where we see the research coming.
Yeah, I personally believe, Ajit, in my clinical practice, people who understand their disease very well and who are taught about that this problem is serious, unless you look into this, being in a close follow-up, maintain your daily intake output charts, and the moment you become positive by around 700, 800 ml, push up your diuretics with the consultation of a doctor, monitor your potassium, creatinine possibly every 2 to 3 weeks. People who have been doing this, families who have been doing this, those patients have been reasonably doing well. The unfortunate problem of our country is clinical inertia on the part of the physicians like us, and on the other side, lack of understanding about the gravity of the disease severity of heart failure by the patients and their families, and very poor follow-up and poor home monitoring of their volume status, daily weight, etc. And if these things, like some hospitals in the south and some in the north have specialized heart failure clinics, which educate their patient and their families. And I think this will go a long way in addition to the drugs alone in reducing mortality and improving survival in heart failure patients. What is your take on this?
I completely agree with that. Like, blood pressure monitoring at home, that's changed BP control. If you can get everything monitored at home, why do you need to see a doctor? In the same way, you can get these things, very simple things, like you said, weight, input, output, stuff like that, you've checked at home. We don't need to have a doctor to listen to come to treat. And just like diabetic glucose monitoring has definitely helped sugar control of patients, I think also this thing should go out of the physician hands to physician assistants and nurse practitioners in what the US talks about, because they are better at following these patients up and questioning them, which the busy physician today in our practice doesn't have time to check all these things up. And you miss the small things like weight, like potassium, like urea creatinine, and things like that. And I think that should go to the physician assistant and the nurse practitioners, who will follow these patients up and then finally handhold it and give it to the patient to manage this. I think this has to be a sequence. It should not be in the doctor, it should be in the PA or the nursing practitioner. And then once they get educated, we create WhatsApp groups. Now we have WhatsApp groups for heart failure. So apart from changing medicines, they can discuss amongst them 15 patients in the heart failure clinic who are discussing their own problems. So that makes the education for heart failure good. We have now WhatsApp group for diabetes. There's one administrator who is not a doctor, who will not change the medication, but will advise everything else, the diet, what all you should do. And when you talk between them as WhatsApp groups, then they know each other's problems and they tell, oh, even I had this and I also got this problem. But this is all good for educated, middle class and above people. But it's the poor people which is a bigger problem, which we need to be very clear how we educate them and how do we set this right among them to think that this is important in their treatment. I think the problem is in India is the poor and the very rich are the most badly treated patients. It is the middle class which is most likely to follow the sensible way of practice of medicine.
Yeah. So I personally would concur with that, Ajit, and I think like Dr. Joshi is here. And I think, Dr. Joshi, the way you have conducted India heart study, you have got a phenomenal network, phenomenal manpower, and attitude in dealing with patients' welfare. So if you have people who are on Zayo, if your people can follow and form a link in educating your Zayo patient about heart failure, give repeated reminders about their drug schedule, reminders about their heart failure visits to their physicians, reminders about their blood tests, reminders about their weekly weight or at least twice weekly weight chart. It will be a great image of the company. Not only image, it will be a service to the society. That's what I feel.
Sure, sir. I think, this is a very good suggestion you have given, and be rest assured, it will be given very serious consideration from our side. And I can assure you that, we will try and do the best that is within us. And we will try to ensure that, the patients who get a prescription of Zayo are followed up, they are followed through, and the best possible counseling, the best possible advice. Of course, with the help of doctors like you, we will certainly take the initiative. And before long, I know you will see that some initiative having been taken by others.
Thank you very much for that. Thank you. Yeah.
Yeah,
That's
thank you.
needed.
Thank you, doctors. I, on my personal behalf and on behalf of Aries, I am very sincerely thank you, for making these interactions and the discussion very, very informative, very enlightening, and very insightful. I'm sure that every doctor who has attended this particular program would have definitely, basically gained more insight into heart failure not only heart failure with reduced ejection fraction, but preserved ejection fraction, the treatment approach, and maybe, as Dr. Ajit Mullasari rightly said, that in Kerala, he found that only 20% of the patients, have been treated according to the international guidelines. We will also try and make sure that, whatever best that we can do to educate and inform and disseminate this information to larger number of physicians or cardiologists through the all eminent doctors like you, we will only make sure that more and more patients are going to be treated in future for heart failure following the international guidelines. I mean, what is within us is definitely what we will certainly do. So thank
Thank you.
you very much, doctors, and thank you very much all the doctors who attended this program. And I wish all of you a very pleasant evening ahead, and I wish you good night. Thank you, sir.
Thank you. Thank you.
Thank you.
Thanks, Ajit. Thank you very much. See you again.
Thank you, Kasturi. Thanks,
Good
Dr.
night.
Jyoti. Yeah.
Good night. Good night.
Thank you.